Thank you, Naresh. And I'd like to take this opportunity to thank Dr. Madhusudan and Dr. Durgesh for having invited me to meet you all. So, first of all, a very happy Doctor's Day to you all. Don't see any cheer. We have to celebrate one day in a year we have for our name, right? So, happy Doctor's Day to you. Right. So, I'm Dr. Karthik. I work as a critical care consultant in Yashoda Hospitals, so Majiguda. So when Dr. Durgesh called me to speak on this topic, tracking parameters in a ventilated patient, so I was thinking what could be discussed in this topic. It's a big topic. There will be overlapping between the previous talk and the next talk that you'll be hearing. So I try to cut down and concentrate on very few topics. So we'll try to discuss at detail few topics which are very important, and you need a good understanding of these topics in order to understand how you ventilate your patients and how you manage your settings on the ventilator. So whenever you keep a ventilator, the importance of that machine is to oxygenate and ventilate your patient. So both of them were not happening in your patient. That is the reason why you have opted to go for a ventilator support, right? So today's agenda of discussion will be on these parameters. So I will divide my discussion into two categories, namely the non-ventilator parameters and the ventilator parameters. You will hear about ventilator parameters in the many talks that will be coming ahead and in the workstations also. But what are more important along with the ventilator parameters are your non-ventilator parameters. So the ventilator which serves your purpose of oxygenation and ventilation. So these two things should be monitored whenever a patient is on ventilator support. So when you are considering tracking any parameter in a mechanically ventilated patient, three questions you should ask yourself. Why are we monitoring? How good are the tools that we are using to monitor? Does monitoring lead to a change in management, and does it change in the outcome? If you put these three questions to you, you will get an answer whether the parameter you are measuring is really important or not. So we'll start with the first parameter, the pulse oximetry. We do regularly use pulse oximetry in every mechanically ventilated patient. You will have pulse ox on his finger, definitely. So what do we do that? So whenever we are ventilating patient, we need to monitor how is the oxygenation happening in the patient, right? So we cannot go on doing ABGs very frequently. You know that it's a cost incurring process and it's an invasive process. So it reduces the need for invasive monitoring in terms of ABGs. And the recent concept, you need not maintain higher supernumerary oxygen saturation. So 98-100% is gone. It is actually injurious. So you need to maintain a saturation of around 94 to 98%. So this comes from your hyperoxia trial. So they have shown that it's an ideal range to keep your oxygenation, right? In your post-cardiac arrest also, this is the ideal range of oxygenation. So you need to have a equipment which gives you the optimum oxygenation monitoring, right? And it's a spectrometer. What do you mean by a spectrometer? If you differentiate the spectral graphs of the constituent of any fluid, you call it a spectrometer, right? So what does this SpO2 do? It causes differentiation. The oxyhemoglobin and deoxyhemoglobin, the spectrums are analyzed and they are divided and gives you a number which is dimensionless, right? And also there is a plethysmographic component in this. So not only oxygenation that you can see in pulse oximetry, you can also see the fluid status. You can see the fluid response. You know that there is hemodynamic interaction that goes on whenever your patient is on ventilator support, right? So you need to know whether you have to give fluid to this patient is having SVR which is low or high. This information also you can get with help of a pulse oximetry. And now the concept of SF ratio. SF ratio has been existent since many days, but it has not been in vogue or in much practice. It's such an easy and such a reliable, and it's a bedside test. You know, it doesn't require any cost. No need to do ABG. Just see the SpO2 on your monitor and divide it by the FiO2 that you're administering on your ventilator. The only one problem you have is the saturation should be somewhere 97% or less. More than 98% or less than 90%, the reliability comes down. Okay, so this SF ratio, if you see, is higher than your PF ratio. So there is an equation to get PF ratio from an SF ratio. I am not shown in this presentation, but you can get it on the net. So if you see the PF ratio of 200, if you want to determine, if you have an SF ratio of 235, it is 80% sensitive and 85% specific to determine a PF ratio of 200, right? So by knowing this SF ratio, you can even get to know the PF ratio. So you can avoid doing frequent ABGs. So oxygenation monitoring becomes easier, right? And this is a correlation. In an ARDS, you are more worried about your ABGs. You want to know PF ratio, whether it's improving, or you want to prone, you want to do ECMO, all these things, right? So when you have an SF ratio at your disposal, make use of this SF ratio. And SF ratio in an ARDS patient, if you have a PF ratio of a severe ARDS is 100, right? So it will be somewhere around 125, the SF ratio, right? And a moderate ARDS will be around 100 to 200, so 225. You take a cutoff like that and see the trend. You can see the trend with help of an SF ratio. Now this is also included in the new ARDS definition. So this is a recently published ARDS definition, that is just a month back it was published, where they have added the SF ratio into the components for diagnosing ARDS, mild, moderate, severe. If you want to term a ARDS, if you don't have an ABG, you can take help of your PF ratio, SF ratio. But the catch is that SpO2 should be lesser than or equal to 97%. So if you have this, you can monitor your SF ratio, and it is validated also now. Right? Plethysmography. So plethysmography tells you about the fluid status, it tells you about the vascular resistance, right? If you are having vasodilated stage, the width of this pulse oximeter becomes more narrow, right? More the vasoconstriction, the width of the pulse oximeter becomes broader. You have a dicrotic notch. Depending on the dicrotic notch, whether you are able to, it is going up or high, you can get to know about the SVR status, right? And depending on the cardiac output, if your cardiac output is low, the amplitude will get decreased. So you can get an idea of hemodynamic condition of the patient as well with help of plethysmography. So both plethysmography and your spectrometry, both components are there in a SpO2 probe, right? So this is helpful in monitoring patients when on ventilator support. Now capnography. Now we have talked about oxygenation, we are talking about ventilation now. So what is ventilation? The ability to wash out the carbon dioxide from your body, right? So SpO2 does not help you in that aspect. So you need to have some parameter which tells you a dynamic change in the ventilation, whether you are able to ventilate the lung which has been affected and the patient's CO2 levels are maintained or not. Why it is important? Because if your CO2 gets up, your acidosis builds up, cardiovascular collapse occurs, worsening will occur. So you need a component to do monitor your ventilation strategy while you are ventilating a patient. So ventilation monitoring can occur with help of your capnography. So you need not do frequent ABGs with that. So you have a non-invasive way, and it's a cheaper alternative when compared to your ABGs, right? And also, many of you and must be anesthetists must be knowing that your ETT placement can be determined with help of EtCO2. You can actually measure your dead space ventilation. So what is the dead space ventilation? There is something called physiological dead space, and there is a dead space that is contributed over and above because of the disease lung. So together this is called a dead space. So if your dead space is increasing, your EtCO2 will help you in determining that there is an increase in dead space. If your lung is recruiting and your dead space is coming down, then your EtCO2 will be nearly correlating with your PCO2, right? So, and also monitoring in different lung conditions like COPD, ARDS, whether your ventilation, carbon dioxides are coming down or going up, especially in the COPD patient, it will be helpful to you. And in CPR, needless to say, in CPR also, when you have a CPR, a low perfusion state, you can see the EtCO2 goes down. And when you successfully achieve a return of spontaneous circulation, the EtCO2 goes up. So it tells you indirectly the evidence that there is a return of the spontaneous circulation. So these are some of the important information that you get with help of capnography. So you can use the SpO2, that is pulse oximetry, and capnography to know these details. So I'll ask you some questions. So it's always me talking, I want you to interact. So can you interpret what are these capnograms? The first one? Very easy. Normal. Okay. Okay. Then no problem. Now we'll go to little difficult one. What is this?
Sharp pain.
Shark fin. Yes, somebody told me shark fin. What is the shark fin appearance on ETCO to suggest you?
Bronchospasm.
Your bronchospasm, right? So your ETCO2 is going up rapidly, right? So it will be helpful in bronchospasm where in asthma COPD you can see such types of capnography. So you can determine how the lung condition is, right? Ventilation doesn't mean only ventilator settings. Ventilation means you have to see the patient overall when the patient is on ventilator, right? Now what is this?
Hypercarbia.
Yeah, hypercarbia. Why is it happening on a ventilator patient?
CO2 retention.
Yes, so you are hypoventilating the patient, right? Your respiratory rate is setting is low, so your carbon dioxide is going up. And what is this? Carbon dioxide is coming down, so you are hyperventilating, respiratory rate is higher, you have increased. What is this? Yeah, so there is trapping of air, so there is a baseline is going up and up, so carbon dioxide is retaining. This, what do you call this? Curare cleft, right? So patient is having spontaneous effort, so your paralysis is not adequate. You need to paralyze the patient properly. And this we have discussed. This is patient is having a steady state and is having drop in the ETCO2. When does it happen suddenly in a ventilated patient? Cardiac arrest, right? And then from here you are having a sudden rise in the ETCO2. When can this happen? Return of spontaneous circulation. It tells you that there is a return of spontaneous circulation. It has been incorporated in ACLS guidelines. These are nothing new that I am telling you, right? But these are the information that you can get in a ventilated patient when the patient is on ventilator support. These are all things you will see when the patient is on ventilator, right? This was what I was talking about, dead space. Normally your PCO2 and ETCO2, if you see, the PCO2 will be slightly higher, but your ETCO2 will be less than PCO2. Why? Because there is a dead space there, right? This dead space is there. Because of your dead space, what happens? The carbon dioxide excretion out of the lung is impaired, right? So your ETCO2 will be lesser than PCO2 in diseased lung. Normally in the normal lung it will be nearly the same. But when you have a diseased lung where you put your ventilator, there will be this difference. So you should never, that is why we never rely on the ETCO2 value for titration of our ventilator support. Invariably we will go to our ABG because of this gradient. If this gradient is increasing, you can assume that there is a dead space ventilation is also increasing. You need to recruit your lung. Okay. Now the other important non-ventilatory parameter you have to measure is the cuff pressures, right? The cuff pressures are very important. Now why is it important? What are the two important reasons why we have to maintain cuff pressure? Yeah, so tracheal mucosal damage you have to avoid. The second thing that you have to maintain is peak airway pressure. Suppose you are not inflating properly, there will be gas leak and then your peak airway pressures will fall, right? There is a leak in the circuit kind of situation will happen. So you have to maintain a balance between both of them. And the third very important, which as an intensivist know, is the aspiration of these micro aspirations can occur and cause your BAF, right? So you have to avoid. So these three things in your mind, that is why your cuff pressures have to be monitored, right? So you have two types of cuff, this is high volume low pressure and this is a low volume high pressure. In ICUs for long duration ventilation, we use high volume low pressure cuffs. Okay, so it decreases the pressure over the tracheal mucosa. And what is the normal tracheal mucosal capillary pressure? Anyone knows? It's around 22 to 30. That is why we don't exceed our pressures in the cuffs more than 30. So around 25 would be ideal. Okay, but it does not hold good in patients who are having very high peak pressures. If you have a higher peak pressure, then invariably there will be leak. So in that conditions, you can go up to maximum of 30, right? And how do you measure? Do you measure your cuff pressures in a ventilated patient in ICU? What do you call that equipment? It's called aneroid manometer, right? Aneroid manometer will help you in determining your cuff pressures, right? Now we'll come to two very important parameters that I will discuss. I have another 15 minutes, I guess, 10 minutes maybe. So the driving pressure, right? Very fascinating topic. Earlier speaker also spoke to you and gave you introduction about this driving pressure. So when you are ventilating a patient, what is very important? We know that out of all the evidence, there is only one very important evidence that tells you, that is low tidal volumes. So if you give low tidal volumes, the outcomes are good. Why did they say that, or what is the thinking behind that? Can anybody say? Say about ARDS, you take an ARDS patient. We have something called baby lung concept. Why is it called baby lung? In a chest, in a pneumonia patient, you have a lot of lung which is damaged, and that is not recruiting, that is not opening up, that is not participating in oxygen transport. What is participating in oxygen transport is the healthy lung. That is very minuscule in the lung. And you are trying to distend that healthy lung at the cost of the diseased lung, right? That is where the damage occurs. That is why the baby lung concept came into existence. So all these, the ARDS net trial, what they have said, you have to start at 6 to 8 ml per kg body weight, target a plateau pressure of 30. All these concepts came. But what is more important than setting a tidal volume is individualizing the tidal volume to the patient's requirement. So it is not the tidal volume that is important. Yes, low tidal volumes definitely help, but in what way do they help? This is the answer to the underlying problem, that is the driving pressure. Everybody will not need a 6 to 8 ml per kg body weight. Is not a uniform setting that you have to keep to every patient, right? That you get to know with help of a driving pressure. What is driving pressure? Is nothing but it is a pressure. So this is a pressure volume curve, right? So this is where your recruitment is above the peak. You are having a tidal ventilation that is happening. So this is the pressure. So pressure is on the x-axis, volume is on the y-axis. So from the pressure that is just above the peak, the recruitment of the lung occurs. So it occurs to a point where the maximum alveolar distension occurs. Okay, so this is your upper inflection point and this is your lower inflection point. Now whatever pressure that is required to tidal ventilate your lung, that is to ventilate your lung, that pressure is called the driving pressure. In a simple terms to say. Am I clear? It's a pressure that is above the peak that you administer in order to achieve a tidal volume. That is the driving pressure. Now how do you derive the driving pressure? It is given by an equation which is nothing but P flat minus P, or a tidal volume by the compliance of the lung. So it is a beautiful concept. See, you have volume, you want to ventilate a healthy lung, you want to recruit a diseased lung. So your recruitment of the diseased lung is taken care by positive and expiratory pressure. But your ventilation of your healthy lung is taken care by the tidal volume. That is why the concept of when to increase peak, when to decrease tidal volume, these two parameters to take into consideration. Always we have been talking about tidal volume, but we have never talked about a concept where you can include peak and tidal volume and derive a parameter where I can say that yes, this is the correct setting for this patient, right? So there, to know which is better to increase, which is less, which is where you have to decrease, this concept of driving pressure came up. Now it's a bit difficult thing, but if you can understand or concentrate, you will get to see. So this is a graph. It looks very complicated, but I'll make it simple. So what you are seeing, the black bars are your peak, right? The black bars. There are three settings here, right? And what you are seeing in the white, these are your driving pressures, and what the peaks are your plateau pressures, right? So the total pressure, that is airway pressure, that is achieved. Now you see the three graphs. If the peak is kept constant and you are increasing the tidal volume, okay, the delta pressure or the driving pressure is increasing, right? Are you understanding? Try to understand. I'll come to in simpler terms. So whenever the driving pressures are increasing, what is happening to the mortality? It is increasing. Okay, the patients are dying because their delta P is increasing. Now if you are increasing peak, see, you are increasing peak sequentially, and you are keeping the driving pressure constant here, there is not much change in the mortality here. But you come to the third situation where you are increasing peak, but your driving pressures are coming down. That is where your driving pressure is coming down, the mortality is decreasing. That is where you have to understand the concept of driving pressure. If you are increasing peak, what you are doing, you are recruiting the lung. Where the lung is recruitable, the total airway pressures are coming down. That is a situation where the driving pressures will be helpful to you. So driving pressures will also come down. It is not that if you are increasing peak, the total airway pressures also will increase. It depends on the recruitability of the lung, right? To know the concept of peak as well as the tidal volume together, they have made this delta pressure or your driving pressure. So it is nothing but the tidal volume that you have to give for the functional lung that is present, right? This is you can't get to know the functional volume of the lung that is there in a diseased lung. How much is the healthy lung, you cannot know. But you can know roughly with the compliance of that lung. If it's a lesser compliance, you need to decrease your tidal volume to decrease your driving pressure. That is what your formula says, right? You'll understand with an example. So you're having a 35-year-old woman who is having a BMI of 40 with COVID-19 ARDS. We have intubated and placed the patient on controlled ventilation with FiO2 of 0.6, tidal volume of 360, rate of 32 and PEEP of 10. So your P-plat measured is 29, your ABG is this. So what would you do? Go through the four situations that I gave you. What would you do? Would you try to increase the VT? Your TCO2 is going up and you improve the respiratory acidosis there. Are you going to increase the FiO2 because you're not happy with 60? You want to have 100. Or you would like to increase the PEEP. But my P-plat is already 29. What is the target P-plat in ARDS? 30, right? So you don't want to go up more than that. If I increase PEEP, maybe I might go up more than that, right? Maybe. I'm saying maybe because I'll come down to this topic again. Or I do nothing. The gas is acceptable for this patient. Your concept of understanding of ARDS ventilation comes into this question, right? What are the principles of ventilation of ARDS? Permissive hypercapnia, low tidal ventilation, and optimal PEEP, right? So if you ask me, I would be happy with this ABG because permissive hypercapnia, I can accept this up to 7.2. Then hypoxia, we already knew 94 to 98 is good enough. Then hypercapnia, I'm not much worried about it. I might stop here. I might say this is okay for this patient. But when the driving pressure comes into picture, then there is a scope of change here, right? So in the most cases in critical care, D would be the ideal correct choice for this question. But if you have a driving pressure at PEEP of 10, see, suppose what is the existent PEEP is 10, right? Last graph question, yeah, PEEP is 10. Now what is the P-plat? We know that P-plat is not, driving pressure nothing but P-plat minus PEEP. So 29 minus 10 is 90, right? So the driving pressure at PEEP of 16, say suppose I increase the PEEP, what happens we'll just see. So what is the driving pressure now? The P-plat minus PEEP, that is 31 minus 16. So it didn't increase much. You went up on the PEEP, but your plateau pressure didn't increase much. What does it say? The lung is recruitable there. So lung is recruitable. So you have to push your PEEP in order to know a value, that is your driving pressure, to know whether it is recruitable lung or not, right? If the lung is recruitable, your driving pressures will be not increasing, okay, even though you increase the PEEP. So what is the ideal range of driving pressure that you should maintain? 15 to 18. That is what they say, that outcomes are not worsened if you maintain the driving pressure, right? So now you are able to determine how much tidal volume I have to keep and how much PEEP I have to keep. So two things you are getting to know with help of this driving pressure, right? This is an example. Even though P-plat is higher than the magic cutoff of 30, the delta PEEP decreased from 19 to 15. So I decreased my driving pressure and the P-plat went up to 31. You might say, sir, you said 30 is the cutoff, now it is 31, so it is harming. No. The amateur trial that they have done, they have compared P-plat, they have compared driving pressure, PEEP, and they have said that driving pressures are way superior to your P-plats, right? So you can omit the 31 and take the advantage of reducing driving pressure and adjust your PEEP and achieve recruitability. Now the second important concept, that is the transpulmonary pressure, right? Why is it important? Do we monitor? Most of us don't. Even in our institute we don't. There's only one major flaw with this thing is monitoring the esophageal pressures or the pleural pressures. Don't have pleural esophageal catheter. It's available, but we don't use it. Why is it important to monitor transpulmonary pressure? For that, you should know what is transpulmonary pressure, right? So you have an alveolar pressure here. This alveolar pressure can be at the end expiratory, that is in the end expiratory, when you hit end expiratory maneuver, when you do on a ventilator, you have a alveolar pressure at that level. And the second alveolar pressure you can have is when you hit the end inspiratory pressure, right? When you hit the end inspiratory pressure, they can be an alveolar pressure. But both these alveolar pressures are affected by an external pressure. That is your mediastinum, your chest wall, your abdomen. So you most of the time you forget that these components can also affect your ventilation, right? So you have to take them also into account, right? How do you take them also into account? And why do you have to take them into account? When you take them into account, the indirect way of getting that pressures is through your pleural pressure. You float a manometer Riles tube into your mid-esophagus and you calculate this pleural pressure. And that pleural pressure, you reduce it from your alveolar pressure to get the transalveolar pressure. Transalveolar means what? Transmural means what? The force that is acting on the wall. That is the summation of the forces across the wall. That is, one force is inside and one force is outside. You minus both these, you get transalveolar pressure. Now this transalveolar pressure can be measured at two different conditions. One at the end inspiratory stage and one in the end expiratory stage. When you hit end inspiratory pause, what are you measuring? The earlier speaker also spoke to you about it. Dr. Durgesh spoke to you. At the end inspiratory stage, what are you measuring? You are measuring your plateau pressures, right? That is your elastic forces that are acting in the lung. Now that is again affected by an external forces. Especially these are high when you have an obese patient. Normally in a lean patient, the pleural pressures are not much high. In an obese patients, these pressures are high. Or in patients there is ascites, or the patients where there is distension of the abdomen, these pressures dominate equally as their alveolar pressure. So when you have that, you have to minus it. So when you minus your pleural pressure from your plateau pressure, you call it end inspiratory transpleural pressure. And when you minus pleural pressure from end, from your PEEP, what do you call it? End expiratory transpleural pressure. So when you are hitting end expiratory, what are you trying to know? Any intrinsic PEEP is there or not? Yes or no? Am I confusing you? I am trying to tell it in a simple terms. When you hit end expiratory pause, what are you trying to know? The total PEEP. Okay, the total PEEP is there. So if you have an intrinsic PEEP, you will get to know it. So you can know at the end of expiration and end of inspiration, you will get two pressures. Why it is important? If you have an obese patient and you are keeping, I'll take two examples. There is one BMI of 17 and another of patient with BMI of 85, which is very difficult to see. But say suppose for the example, I am setting a PEEP of 24 in both these patients. Okay, but you know that this patient is lean, and in lean patients external forces may not predominantly act. So this might be over distending his alveoli. Yes, but when you come to a obese patient, because of the chest wall, the weight of the chest wall and the abdominal pressure, what happens is this pressure is acting at a very high level. Now you can't neglect that. You have to take that also into account. So when you minus the end expiratory pressure with your pleural pressure, what is the net pressure that you are giving? Hello? Maths? 24 minus 24? 0. What are you recruiting the patient with? You are not recruiting the patient. So now this concept of transalveolar pressure comes in obese patients. You have to calculate the pleural pressure and then you have to calculate the transalveolar pressure. And depending on the transalveolar pressure, you should determine the patient is being over distended lung is happening, or you are not able to recruit the patient. So you are doing all these things blindly all these days. Now with help of pleural pressure, you can get a better idea. This is what is precision medicine. You are trying to tailor-make your concepts of ventilation to specific patient with specific body phenotypes, right? So this is how it occurs in your screen and ventilator. There are Hamilton ventilators where you can measure your pleural pressure. So this is nothing but your pressure times scalar Then this is the flow time scalar. This is your esophageal pressure. So I am floating a catheter with cyclical respirations. You are seeing that the esophageal pressure or the pleural pressure, which is surrogate for the pleural pressures, are being seen. Now you see the transpulmonary pressure. This is around 40, says about 35 like that. And then you are ventilating here, the pleural pressure is 20. So what is it coming to difference? Say about 40 minus 20, approximately around 20 is your transpulmonary pressure. So you're not over distending the patient. Suppose you see this pressure time scalar, you might think that I'm over distending the lung. But for this patient, you're not over distending because now you have transpulmonary pressure with you. Likewise, if I see at the end of PEEP, see what is the PEEP here in pressure time scalar? See the graph is starting around 20 here. So you have put a PEEP of 20 here. Now you know that your pressures are nearly 20, more than 20 here. See 24 maybe, your pleural pressure is 24. Okay, so 24 minus 20, there is no PEEP that you are giving to your patient. Hello, understand? No PEEP you are giving to the patient. You are thinking you are giving 20 PEEP, but for that patient it is 0. That is why if you see the baseline of your transpulmonary pressure is going into negative here. Right? This is not what you want to achieve in your setting. So this concept of transalveolar pressure, concept of driving pressure are very, very important concepts. And it's a very difficult if you read to understand. You need to see with examples and implement bedside to know these things. Right? So how do we implement the transpulmonary pressure? It's simple. It's a vague thing to tell you briefly. In case you get a pleural catheter hold, try to use it also and to titrate it. First you measure P-flat. Okay, you get it with help of inspiratory pause. Right? Once you perform an inspiratory hold maneuver and measure a P-flat, at same time you record what is the esophageal pressure. And then you take a transpulmonary pressure and inspiration. This is transpulmonary pressure and inspiration. That is P-flat minus pleural pressure. And this is your end inspiratory TPP. So keep this no greater than 25. So this is a vague marker, a study that they have done and they have seen outcomes. So from that study I am trying to quote you an arbitrary value. Right? So 25. Now you perform an end expiratory hold and you measure your pleural pressure at end expiration. Okay. And now again there is a small catch here. Suppose you are having intrinsic PEEP like in COPD. It is not the PEEP setting that you should take into consideration, but the total PEEP that is there in the patient. Then there is a slight variation that you need to take in the value. But if you don't have much of intrinsic PEEP, PEEP is good enough to take in the difference. Right? You have to take the difference of the PEEP and your esophageal pressure. That will give you your end expiratory transpulmonary pressure. Your end expiratory transpulmonary pressure should be higher than 0. Obviously it should be higher than 0. Otherwise at least 5 PEEP is your physiological PEEP. You should have at least that. But what they say is, but no probable more than 10. Right? So if you are targeting transpulmonary pressures, this is what your targets are. If you are not having transpulmonary pressure, at least have an idea or concept of transalveolar pressure and see where you have to increase PEEP. Every patient might not require 14 PEEP is not, we have an assumption that 14 is very high PEEP. If we go more than that, we will cause barotrauma. Yes, in a skinny patient. In an obese patient, that does not hold good. So you have to clinically see. If you are having a luxury of having a pleural catheter, you can monitor these things. Okay. I'll not go much into the respiratory system pressure volume curve and its uses because this has been dealt in detail and it's to be spoken again by the further speakers also. Right? So these are some of the monitors that will be in my mind when I am ventilating the patient. Right? So with these brief words, I would like to conclude my talk and thank you all for patience.